Do I have to use THP induction, or can I extrapolate and start with TDXT induction?
Do you think competitors with first-line induction to maintenance designs impact using TDXT in the first line?
So it's a good question. There are two trials to consider. The first one is PATINA. That trial looked at patients who were on THP induction and then switched to HP maintenance. The addition of palbociclib was associated with improvement in progression-free survival. And this was for patients with hormone receptor positive, HER2 positive disease, also called triple positive, by some providers. So in that setting, you could see improvement in PFS. And then at SABCS 2025, we saw the results of HER2CLIMB-05, where the addition of tucatinib to HP, both ER positive and ER negative, was associated with improvement in PFS. Now, neither of these regimens are FDA approved, but if they become FDA approved, then the question would be, if I use palbociclib or tucatinib, do I have to use THP induction, or can I extrapolate and start with TDXT induction? And when I go to HP maintenance, then consider these therapies. That's an open question at this time.
Yeah, I think practically, I might start with TDXT plus P, since I think both of those maintenance studies, the PATINA as well as HER2CLIMB-05, don't really shed light on what to do for induction. And then if you make it to a maintenance phase, I think you have your pick with maintenance strategies in the right population. But otherwise, I might continue TDXT plus P indefinitely as long as patient is tolerating. Is that what you would do?
I would do the same. Yeah.
Sounds good. Any elements of these trials, either DB09 or the maintenance strategy studies with PATINA or HER2CLIMB-05, that might affect real-world treatment decisions?
I think over time, we'll probably have data from the real-world setting where some providers would be doing this TDXT and HP maintenance. So besides the Demeter study, I think the real-world data would be helpful because that can influence clinical practice.
Any other, up-and-coming agents that you see sort of affecting this space of HER2-positive metastatic disease?
In the first-line setting, no. The results with TDXT are so good that it'll be difficult for any other drug, at least in the foreseeable future, to change that. I think what we need to focus more now is how do we manage the AEs, make the drug more tolerable for patients, maybe a lower dose, better supportive therapy, and also the idea of induction maintenance. That's where the field is headed.
Great point. This is kind of the first change in first-line therapy induction in greater than 10 years, so we have our homework to do. Wonderful. Well, I think we touched on a lot of things. We have some key takeaways that we want our audience to go home with. One is that the DB09 regimen demonstrates a meaningful evolution or a change in the standard of care for first-line therapy in metastatic HER2-positive disease with TDXT plus pertuzumab. We discussed selection of patients for DB09 and really touched on the fact that we think this is broadly applicable in this patient population, and key to set expectations on adverse events as well as managing and monitoring over time. In terms of sequencing and what comes next, I think we still have all the agents that are already available to us, available in the later line setting. There's also maintenance strategies that may be employed if a patient needs to come off TDXT. So a lot of great options, I'd say. Any closing remarks, Dr. Bardia?
And that's why we do clinical trials, and to see drugs that are improving survival, helping patients live longer, I think is fantastic. We also focus on how to make patients live better. And so the supportive therapy, the focus on quality of life is also very important.